Good morning, I'm Adrian Dix, BC's Minister of Health. Joining me today is Dr. Bonnie Henry, BC's Provincial Health Officer. We're grateful to be here on the traditional territories of the Lekwungen-speaking people, the Songhees and the Esquimalt First Nations. Grateful to be here on their lands. Since September, we've all been focused on the importance of being prepared for respiratory illness season. And as we know from our experience and what we're seeing in BC, and in other jurisdictions across Canada and around the world, the season is now upon us, and COVID-19 is still with us. We know what's at stake, we know what's required, we know what to do to take care. We're starting to see an increase in influenza cases, so staying diligent to keep ourselves, our loved ones, and our community safe is just that much more important. In addition to COVID-19 and influenza, this year we have other viruses that cause respiratory illnesses, such as RSV, which has not been as present in past years, although it was present last year, to agree, but has been a factor that we're dealing with as well. We know as the weather gets colder, we will gather more indoors, and we know that's okay. But after all we've been through, we also know it's important to do it safely. That means especially wearing a mask if we have mild symptoms, and considering wearing a mask in indoor public spaces. It means, most importantly, staying home when we're sick. And it means washing our hands frequently with soap and water. As critical as these essential actions are, keeping us healthy and safe, getting vaccinated is our best protection. We know this. So we all need to act right away to register and book an appointment for our COVID-19 and influenza shots. It's never been easier, and we see that in the extraordinary take-up already, and we can safely get the two shots at the same time. As British Columbians, we demonstrate our commitment to protecting ourselves, our loved ones, and our communities by following public health guidelines and getting vaccinated in record numbers. More than 90% of us over age 12 have received at least 2 doses of the COVID-19 vaccine. This number grows every day. And since the fall COVID-19 booster program began on September 1st, nearly 1.2 million fall boosters have been administered to people in BC over the age of 12, 96% of which are bivalent vaccine products. And as of this morning, over 1.2 million of us have received our flu shots. That's more than twice as much as this time last year. We started earlier, and that has an impact. We're also seeing a very strong take-up, but we need that to continue. Put simply, we know what's at stake, and we know what's required, and we know what to do to take care. And it's now my honor to introduce Dr. Bonnie Henry to discuss the respiratory illness season this fall and winter. Dr. Henry?
All right. Thank you very much. It's an honor to be here today. It's been a while. I too would like to acknowledge that we're here on the traditional territories of the Lekwungen-speaking people, the Songhees and Esquimalt First Nations, and we're very grateful to that. I also want to point out that today is Louis Riel Day, which is a time to learn and celebrate Métis history, values, and culture. And the first step that we've learned in truth and reconciliation is truth. And I encourage everyone to make an effort to learn about the truth behind the role that Louis Riel played and the unique heritage and inherent rights of Métis peoples in this country and in this province. In September, we talked about what we might expect as we moved into the respiratory illness season here in British Columbia. We're now in that place, as expected, and the respiratory season is unfolding as we expected it would. But we are in a very different place than we were a year ago. And that is largely because we've done a number of things. We started to move again, to travel internationally, to travel globally, to travel across the country, to travel within the province. And we are seeing the return of common respiratory viruses that have been mostly absent in the last 2 years. We know that the 3 main viruses we need to pay attention to and be careful about are now COVID-19 is into that mix, but also influenza and RSV, and there are a number of other respiratory viruses that have been causing illness, and I'll be walking us through that now. Our focus throughout this pandemic and in every respiratory season prior to the pandemic has really been about protecting people who are at highest risk of severe illness or death, protecting our health care system, our capacity, and we know that's been stretched for many reasons, not the least of which is respiratory illnesses, and keeping our communities, our families and our communities safe and functioning for all the other important things that we need to do, which includes bringing people safely back together again. So I'm going to start with talking about where we are today. Only about 51% of eligible children have received their first dose of COVID-19 vaccines. And I'm going to show some data about why we need to pay attention to that. A year ago, we didn't have vaccines for children. We now do. And that's an important piece of protecting children from a virus that we know doesn't cause severe illness in most children, but can. And we know that children can also be part of transmitting it within households and families particularly. We know that over 86% of people 5 and over have received at least 2 doses of COVID-19 vaccines, and that is great. That means that we have a level of immunity that is higher than we've ever had, and that we know that that gives us longer-term protection against severe illness, even in people who are who have immune-compromising conditions and in older people. And most importantly, we also know that a large proportion of British Columbians have received a booster dose, and the fall booster is incredibly important right now. We now have more protection against severe illness because of this, because of vaccination, but also as we presented in September, we also have infection-induced immunity. And we have treatments. We have treatments for COVID-19, including Paxlovid, and we have treatments for influenza, including oseltamivir. So we know from the seroprevalence that about 90% of people in British Columbia have built some immunity to the virus through vaccination, through infection, or, for many people, both. But we are also learning that our immunity is complex, and I've talked about this many times. We have that short-term protection with antibodies in our blood that respond when we're exposed to the virus, and we know that those antibodies protect against getting infected, having that virus cause infection in the first place. But we know that whether those antibodies are from previous infection or from vaccine, they do go down over time. And usually that's around somewhere about 3 or 4 months we start to see a decrease in that protection against infection. But as we've talked about many times, we know that that longer lasting second part of our immune system, the memory cells, the cell-mediated immunity, last much longer and give strong protection against severe illness, hospitalization, and death after 2 doses, but also that gets boosted up when you have a booster dose. So the combination now of immunity from infection and vaccination and the combinations that we've seen, and it is complex. People have had 2 doses and 1 infection, or 3 doses and an infection, or several infections and then vaccination, and all of that builds a complex picture of immunity that makes it challenging for us to tailor who needs what. What we do know is that right now it's really important for people to get that booster dose to protect us all from infection and help dampen down the transmission of COVID-19. And we know that the combinations we've seen mean that most people in BC are no longer at risk of severe illness and hospitalization, even in long-term care, even people who are immune compromised. And that is really important. So what are we seeing right now? In terms of hospitalizations and deaths, as you know, our testing now is focused on people who will need potentially need treatment or may end up with more severe illness. And so that's not a reflection of the amount of transmission that's happening in our community. But what is important is following the people who have severe illness. And as we've seen in the last few weeks, our hospitalization rate has actually started to come down, which is good news. The daily deaths, as we started back in April, reporting on all-cause mortality at 30 days, that has trickled along and is also coming down slightly. We know that the cause of death, the underlying cause of death being COVID, is only about 40% of those. I'll have a bit more information about that. So if we look at hospitalization rates by age, we all along in this pandemic, we have seen that it is older people that are more likely to get severe illness, more likely to be in hospital, and more likely to die. And thankfully, with the booster dose program that we've started and focusing on primarily making sure that people who are older get that dose, we have now started to see decrease in hospitalization in particularly people over the age 80, which is the highest risk group for COVID. Our 30-day mortality, as you know, as we get the underlying cause of death data from vital statistics, we see that about 30 to 40% of people who die with a positive COVID test, COVID is one of the reasons why they've died, and that's remained relatively steady through the last several months. If we look again at hospitalizations and we standardize it by age, again, clearly we see that anybody, compared to the same age person who's non-vaccinated, people who are vaccinated with at least 2 doses have half the rate of hospitalization, critical care, or risk of dying. And the same, and that again, it's 4 times higher if we look at people who've had at least 1 booster dose. Really important to remember that this makes a difference. This makes a difference for your own personal health, but it also makes a difference on your risk of ending up in hospital or passing it on to others. The most prevalent lineages, as you know, through this whole pandemic, we've been doing whole genome sequencing to help us understand what is being transmitted around the community in British Columbia. And there's a whole large gray part in the most recent ones. So this is when Omicron, the pink and purple are Omicron, and the purple, different shades of purple, are basically BA5. And as we have reduced the amount of PCR testing we're doing, there remains a whole bunch of others that we need to look at. But we have been sequencing those others, and this is what makes up that gray box. As you can see, it's a whole variety of slightly different mutations, but all of these are Omicron BA5. So that's really important, and we've seen the evolutionary virologists have told us that we're seeing what they call a confluence, where there's not a new strain that's arising that's causing very different symptoms or very different transmission rates. What we're seeing is it's all different variations around the same sort of variant. And most of it is as a different variants of the BA5 with slightly different mutations. And so we're continuing to follow that really closely. It is unlikely, given what I've just talked about with our immune level of immunity that we have in British Columbia, that we're going to see something markedly different arise in the near term here in British Columbia. But we are also watching what's happening globally, because we know that globally that's where Omicron arose. But we would get some warning around if we started to see a different new strain arise outside of British Columbia or Canada. The other thing that we've been monitoring carefully is wastewater samples, and as you can see, we've seen a gradual decrease in leveling off, and it's been a little bit up and down over the last few weeks, but mostly low and stable. And these are the ones from the Lower Mainland. We have now expanded our wastewater sampling to the interior and island here, but we're still at the point of calibrating those, so it takes some time to get enough data points to be able to look at trends over time. But what we are not seeing is any dramatic increases in the amount of virus that we're seeing in wastewater samples here on the island or in the interior as well, and we're working on being able to do this in communities in the north. This is something that's outside of our testing parameters and changing in testing, and it helps us give a barometer of what's going on. The other things that we're looking at and trying to validate are being able to use these same samples to look at how much influenza or RSV we have circulating in our community. And these are relatively new techniques. It's not something that's easy to do, and so our lab is at the forefront of developing the ability to do that to help us understand other viruses that are in our community as well. So what else is going on in British Columbia? one of the things that we monitor over time, and this is all on the new dashboard that we're building on the BC CDC. So in the past, we've had our influenza surveillance bulletin that would come out periodically, and now we've moved it on to a centralized database where it's interactive, so you can go on that in the BC CDC website, and the link will be in the news in the briefing note. So one of the things that we have been watching over time is physician billets and community visits to healthcare practitioners, so physicians, nurse practitioners, for respiratory symptoms. And so this could be anything. This is a clinical diagnosis of what we like to call influenza-like illness. So it's anything that's causing a respiratory symptoms. And we can see that in December and January of last year, we had that big peak, and that was when Omicron first came in. And we're now starting to see a gradual and a more steeper increase within the last 2 weeks of respiratory illness in British Columbia. If we look at that and break it down by age, we see that that increase has been driven by respiratory illness in young people. And that should be no surprise. We've been seeing that in younger people needing ICU care, and younger people going to emergency departments and seeking treatment across the province. One of the things that we see, though, is it's across all age groups. And we know that school-age children are mixing more, but also younger children. And it's important to reflect on that, because there are things that we need to do to think about protecting younger children as well. If we look at what's causing that illness, especially in the last little while, we look at laboratory data that helps us understand what pathogens are causing illness. And this comes from swabs that are taken of people with influenza-like illness or respiratory illness across the province. And we do laboratory tests to look at a variety of pathogens. And what we can see is that for the last couple of months, one of the main causes of respiratory illness across the province has been enteroviruses and rhinoviruses. And those are ones that we call the common cold. And enteroviruses in particular can also cause some more severe illness. We've seen EVD, enterovirus D68, which is one particular strain of the virus that can cause more severe illness in children. And that has been one of the drivers of children needing hospital care or medical care over the last few months. In the last week and a half, we've also seen, you can see in a purple line there, that dramatic increase in influenza. And this is almost all influenza A, mostly influenza A, H3, and N1, although we haven't figured that out yet, in particular, sorry, H3N2 and H1N1. What we've seen, though, is a leveling off of SARS-CoV-2, so that's not what's causing most of the respiratory illness that we're seeing right now. And we've seen an uptick in RSV, not the dramatic increase that we're seeing in influenza, but still an important increase. If we look at the BC Children's Hospital laboratory data, which is something that gives us an understanding of what's happening in younger people across the province, it's representative but not inclusive. And if we look at the upper picture has, the smaller picture has SARS-CoV-2 included. And then if we take that out, because that was the large proportion, and we saw lots of younger people having Omicron essentially since January of last year. But if we take that out, the light green is RSV. And so we did see in BC a fair amount of RSV circulating last winter. And that's important to note. One of the concerns that we've had and that I've talked about is that we have several cohorts of young people who have never been exposed to RSV before, which we're seeing in some parts of the country, particularly Ontario. We're seeing a lot of that, where RSV is causing not more severe illness, but because more children have not yet developed immunity to it, because they weren't exposed to it over the last few years, it's causing an increased numbers of children requiring hospital care. We're not seeing the same picture yet here in BC, though we're continuing to watch. We did have quite a lot of RSV circulating last fall, and we're starting to see it increase now. But what we're really seeing that's making a difference in this province right now in children is influenza, and influenza A in particular. So the other thing that so I'll just talk about through these quickly. So if we look at SARS-CoV-2 and at the Children's Hospital, we can see very small numbers and the percent positivity sort of bouncing around in small numbers. So it's not the main driver of what's causing people to need hospital care right now. RSV is increasing, and the percent positivity of the tests is increasing. The number of children requiring the test has increased as well. But really where we're seeing the big increase in young people is influenza. And I say this to make the point, really importantly, influenza is a vaccine-preventable disease. We have good vaccines that work well in children. Children over the age of 6 months of age are eligible for influenza vaccine for free. There's also the nasal spray influenza vaccine that's available for children that's very effective. And this is a warning to us. We're starting to see influenza circulating. We know that children often don't get very sick with it, but some of them do. But they can also pass it on to others. So this is the time to make sure we're best protecting children by getting them vaccinated against this virus in particular. I want to just talk a little bit about, it's not possible now to tell if you have symptoms of COVID, influenza, enterovirus, RSV. They all cause very similar types of illness in most people across the board. But the actions we take to prevent the transmission and to look after ourselves are the same. One of the things that we've had in place for a long time is saying, if you have COVID, you need to stay home for 5 days. That's no longer relevant in the setting that we are in now. Instead, if you have symptoms of any respiratory illness, we recommend, the guidance is to stay home and to limit close contact with others until you no longer have a fever and you're well enough to participate in your usual daily activities. That's what we need to think about. It's the symptoms themselves. It's hard to differentiate if it's one or the other, and it doesn't really matter in terms of our risk to others. But we need to be cautious. We need to be cautious, and that means if you have any symptoms at all, even mild symptoms, wear a mask when you're around others, even in the home. And one of the things that where masks actually are more effective is when you're in close contact indoors with somebody. And we know that many of these viruses are transmitted within families, between siblings, between parents and children, grandparents and others, in those settings where we don't think about wearing masks. And it is, particularly if you have somebody who's more vulnerable within your household or you have an infant, you can protect them by trying to keep people who are sick away from them as much as possible and to wear masks in those settings. If you're sick at all, postponing non-essential close contact with people who may be at higher risk or at higher risk of getting sicker with these viruses, so seniors, elders, infants in particular, and young children, and those who are immune compromised. If you can postpone those visits, that would be good, particularly bringing children in to visit people in long-term care. When there's a lot of viruses around and people have the sniffles, it's very risky that you can bring that into a higher risk setting. If you can't postpone those non-essential visits, then it is important to reduce the amount of time that you spend in the place, to wear a mask, and to take all of those other measures like hand hygiene, looking at ventilation, looking at whether you can do it outdoors, etc. We also need to avoid those social settings, especially indoors, where we may inadvertently spread to others. So move the visit outside, wear a mask. As I mentioned, think about not taking children along if there is illness circulating in their class or in the family. If you do have symptoms, but it's essential to be in close contact with others, then we need to use all of our preventive tools. So masking, washing hands, following respiratory etiquette, paying attention to space and distance and ventilation. And that goes for common spaces like workplaces, schools, to reduce risks of transmission. And I would like to take a minute to talk about masks and where they are most useful. Last year we had mask mandates, but they were not in isolation. It was in the context of what we were facing at the time, including severe illness in many adults, as immunization was increasing, but not yet at the level that we needed. We had no vaccines available for children. We had adults who were getting very sick and putting pressure on our ICUs and hospitals. Plus, we had absenteeism of healthcare workers, and many workplaces outside of healthcare were working from home. We had gathering restrictions and travel restrictions and barriers and capacity limits. We had reduced activities in schools. And in that context, masks were incredibly important and necessary in a broad range of settings, including the structured settings like workplaces and transit and schools. We are in a different situation now, as I've mentioned. We have a very high level of immunity against COVID. We have both immunity through vaccinations for influenza and treatments. We have treatments for influenza, we have treatments for COVID, we have treatments for RSV. Masks still need to be available and accepted in workplaces, on transit, and other indoor settings. We know that we had last year, for example, restricted activities for children, and that had consequences for the way schools functioned and for the health and well-being of children. We have learned through this pandemic the critical role that schools play, not just for children, but for families and communities. And it is more than just education in a school setting, as we know. It's the physical, emotional, social needs that school communities provide for children and families. And we've pulled together in this province to ensure that we keep these essential environments open. And I really, again, our gratitude goes to all of the educators, staff, and parents and communities who made this a safe reality for our children. I will also say every single school in British Columbia has had a ventilation assessment, and we continue to make that a priority. We have a committee that is continuing to meet weekly to review what's happening in schools. We're monitoring absenteeism, and schools remain a supportive, inclusive environments where masks are available in every class and where it is accepted and encouraged to wear a mask whenever people feel they need to. But I think we all need to recognize we are all human, and masks are protective equipment, but they're only as effective as we make them. And that can be a challenge, especially for children sometimes. And I do not believe we need that heavy hand of a mandate to send a clear message that masks are an important tool that we can all use during this time and in every respiratory season. We should have one with us. We should use it in situations where it makes sense. And it may differ depending on the situation. I think about it, I may wear a mask one day on the bus if it's crowded, the windows are closed, or if I'm worried that I might be getting the sniffles. But on another day, if I'm feeling fine and there's lots of space and good ventilation, I may choose not to, and that's okay. I think those are the decisions we have to bring masks in as a tool that we can use when it's appropriate, when it's necessary. If I have a sick child at home, I may wear a mask in my workplace to be extra cautious, even though I'm feeling well and I need to go and I can go into work. Or I may participate in a meeting where there's more people in a crowded setting remotely rather than in person. The settings where masking continues to be essential are in healthcare settings. And we have a mandate in all of our healthcare settings across this province at all times. These tools are necessary all the time. So we have vaccination requirements for healthcare workers across our healthcare settings in this province, and everybody in long-term care, hospitals, vaccination clinics, community clinics wears masks throughout this respiratory season. These are important additional measures in those places where it matters the most. And additional measures we have in long-term care are including that residents are protected through testing and ensuring visitors are also vaccinated. All of these are important, but our best protection remains protecting us from getting infected in the first place through immunization. And as we can see, we have very high rates of immunization and high rates of boosters protecting people, particularly at older age, but we have work to do for younger children. So I encourage everybody, now's the time to make that appointment. You can get your influenza vaccination, your COVID booster at the same time. As well, as I mentioned, there's nasal flu shots for children, and flu vaccines are available to everyone 6 months of age and older. The other thing that is different this year is that we have enhanced influenza vaccines for all seniors over the age of 65, and those give additional protection against influenza than the standard dose vaccines because they stimulate a stronger immune response. So I encourage everyone to register and book your appointment for your flu shot and your fall booster now. All right. So as we are going through the respiratory season, and as I mentioned, we knew that this was coming, and we've been preparing for this as best we can, and the things that we all do together collectively now will make a difference as we get through this next few months. As we all look forward to the holiday season as well, it's important to keep our personal toolkit handy. We have many tools that can help protect us, our loved ones, our community from all of these viruses that are circulating now. First and foremost is getting vaccinated, but also having a mask with you, wearing it in those crowded indoor settings, wearing it when you're not sure if you have the sniffles or not, doing that health check every day for yourself and your children, avoiding touching your face and eyes and nose, using respiratory etiquette, coughing in your sneeze, covering your cough, disposing of your tissues, remembering your hand hygiene. You can also choose where you gather and when you gather with friends and family, looking for open spaces with good airflow, looking at postponing some of those visits if there's illness in the family. Regularly cleaning surfaces, paying attention to ventilation. And if you're feeling unwell, stay home and avoid contact with others, especially people who may be more at risk. I want to thank everybody in British Columbia for their continued commitment, and we've seen this all along, of recognizing that we're all coming from different places and that we need to be supportive of each other. If you're wearing a mask today, given the situation that you're in, we need to be supportive of that too. And that means this is how we're going together to get through this respiratory season and practice, get it, be part of how we do this every year, as we know that these viruses are going to be coming around again. Thank you. I'll turn it back to Minister Dix.
Thank you, Dr. Henry. Dr. Henry's leaving me with a clicker, which is a high show. Oh, you're going to, yeah, only one person has the clicker here. So, thank you, Dr. Henry. Just going to go on with a presentation with respect to current hospitalization status, where we are, and where we expect to be. In September, we said that we had to prepare our hospitals for respiratory illness season and a possible surge in patients. Our hospitals have well-established systems in place to manage high patient volumes, including regional and provincial surge plans. They've been planning for various scenarios and are ready to respond to an influx of patients requiring care for respiratory illnesses. Plans are in place, and fortunately, in large measure, we are not at a point where we need to implement them yet, but we're ready if we need to. Our readiness plans include improving and increasing hospital bed capacity and emergency department efficiency. We go on to the next slide, which I think is this one. No, it's back one now. We're still on that one, yeah. In terms of capacity, in October, COVID-19 hospitalizations, as Dr. Henry has said, were down, but they're relatively similar to September levels. Hospital occupancy is up from September, rising by 1 point to 95.4% of base bed capacity. And when we include surge beds in those numbers, the occupancy increase to this point in November is 2.2%. We see that reflected in that slide. There's a lot of interest in children's critical care capacity. I would note that this changes, and as you can see, can change significantly from day to day, because overall in the province we have amongst children's high acuity beds and neonatal intensive care beds, we have 243 beds, but a change of one or two can very significantly change the information in each site. For example, on Monday there was an overcapacity at Kelowna General Hospital. Today we are under capacity for that because there's a small number of beds, and the reduction or 2 or 3 can significantly change those numbers. The pediatric ICU rates tend to change more, of course, as we've said, but essentially we are at, as of today, as of yesterday, it was 67%. I think we reported that in our children's critical care beds today at 64%. In terms of our children's high acuity units, it's up slightly from 74 to 76 from yesterday to today to give you a sense of the day-to-day changes. The next slide, please. You see in terms of emergency department visits over the last period, we have seen an increase overall in November on average from where we were in September and October. In September and October, it was roughly 6,700 visits a day. In November, that number is up to 6,765, understanding that at different sites, that can be a varied amount on different days. Next slide, please. In terms of bed management, our emergency department and hospital capacity task group is integrating priority actions into health authority surge response plans. These plans include improving emergency department triage processes to better and more quickly connect patients with community care to avoid or shorten hospital stays. They also include hiring more patient care coordinators to improve the flow of patients through hospitals and heightening integration with urgent and primary care centers, and strengthening communications to patients, as well as ensuring support to rural and remote care, and all of the investments we've made in patient transport. Next slide. Pediatric, in terms of pediatric ICUs, we have a dedicated provincial pediatric team that coordinates our pediatric resources. We have pediatric ICUs, of course, located at BC Children's, Victoria General, and the University of Northern British Columbia, and neonatal ICU beds in many jurisdictions and many hospitals across the province. This dedicated team is focused on a daily basis on what's at stake and responding to the demands of respiratory illness season. And so you see that, and you see that in the response specifically at that care and some of the numbers I spoke about just a few minutes ago. If we move on to the next slide, please. In terms of increasing our capacity in community, this was a part of our plans, and that means something in a term which I'll explain. It's called alternate level of care, or ALC patients. Essentially, those are patients who are in hospital but are really ready or should be in long-term care. And they're being provided hospital care as they either wait for a long-term care transfer or an available bed. And that is one of the ways that we measure patient flow in the system, and also it's a possible place where you can create capacity in the system by creating more access to long-term care beds in the community. And that's precisely what we've been doing. We've seen in October a reduction of ALC patients as a percentage of occupied beds that is decreased. And we have specific measures that we put in place, including the opening of beds to ensure that we're ready as we need to address potential demands on capacity from respiratory illness season. So we're adding beds across all health authorities in long-term care to allow for more space in acute care. This is not an issue of moving acute care patients to long-term care. It's a case of patients who are long-term care patients but in acute care moving over to long-term care and creating capacity at a time when there are capacity pressures in the system. And there's lots of details by health authorities, and you all have the PowerPoint, and I'll let you go through those. And the next slide, I think. That's it. Yep. Just to say finally that, you know, we're opening long-term care beds, and we're supporting operators of long-term care beds who are often health authorities or often private for-profit or non-profit providers, including staffing float teams and virtual nursing services, and providing casual staff with more flexible opportunities for regular part-time and full-time work. We're implementing strategies for patients who can be supported at home, including providing casual staff opportunities for regular full-time and part-time work, adding capacity in home support and in adult day programs, and ensuring quicker access to transitional care for complex patients discharged from the hospitals. Our hospitals need to be ready, and as you can see from Dr. Henry's presentation, we need to continue to be ready as we go through this season. We are behind, thankfully, other jurisdictions in the country in terms of these pressures, but we need to prepare for them. And we all finally, with those plans in place, need to do our part. We need to be ready too. We need to get vaccinated. We need to wear a mask, especially if we have mild symptoms. We need to stay home if we're sick, and we need to wash our hands frequently. And we need to keep doing what we know, because what we know works. And with that, Dr. Henry and I are happy to take your questions.
Thank you. A reminder to media on the line, please press *1 to enter the queue for the opportunity to ask a question and a follow-up. We're going to start here in the room today. First question comes from Binder Sajan, CTV News.
Hi. Just wondering if you're a parent of a child who gets fairly sick. I know we've talked about the ICU numbers, but you're heading to hospital, often facing hours-long waits, whether you're at BC Children's or at other hospitals around the province. So I know you've talked about the work that's being done. Does that help immediately, though, for the people who are waiting hours and hours and hours? And what advice do you give parents who are very worried about their sick little ones?
Yeah, so I know this is a challenge that we face a lot, and it's so hard to know with young children particularly. So I encourage people to talk to their primary care provider, to call 811 where they can get advice as well. And yes, when you do go to emergency departments, some of them are very busy, but if you are concerned about your child, don't put off that visit if you need to go to the emergency department. You will be seen, you will be triaged, and we will all need to be patient, but we know that it is important to get that care if you need it. I don't know if you want to talk about it. It is a challenge.
Just to say, the important way that the capacity changes are important is it creates space on the wards. Sometimes you'll hear a story of someone who's admitted to the hospital, but then in the emergency room, and it's an important measure of patient flow in the hospital. And that sounds like a technical thing, but it's important. We want people who are sick and are admitted to the hospital to be on the wards, because that allows less pressure and a less sense of pressure in emergency rooms. So it's important for that reason. And fundamentally, if you don't have space and they're admitted, they have to stay in the emergency room, and that's a problem for everybody who works in the emergency room. So that's why one of the reasons it's important. It's a capacity issue that's important, as do all the measures we're taking, adding patient care coordinators and others to help people in those periods. We have at different hospitals on consecutive days, sometimes significantly different numbers of patients coming in. And as Dr. Henry has said, everyone gets triaged, right? And it's a challenge sometimes. There are other services available. 811, prior to the pandemic, we did about 1,050 calls a day. At the height of the pandemic, that was over 4,000 in a day. So we dramatically expanded that service. It's come back down to a sort of daily average of about 1,800. I check every morning to see how we're doing in response to those calls, whether we're losing them. Yesterday, we responded to, I think, over 99% of the calls, right? So we have created capacity there to assist, and obviously through the other actions we're taking. But it's a challenging time. It's challenging for healthcare workers. We sometimes have reported on the number of healthcare workers who are off sick that typically in the pre-COVID era, that would be on one of the bases of healthcare workers we use, about 8,000 to 9,000 workers. Last week was about 15,900, and of course, that sickness comes inconsistently across the province and can hit an entire group of workers in a particular part of an acute care hospital, whatever the nature of the illness is. So that's one of the challenges facing the healthcare system in every part of the country, and certainly here in BC.
Follow-up, Binder?
Yeah, and speaking of that issue in terms of like the capacity and the demands differ on a day-to-day basis. I know you talk about having like surge beds available, but if you do have healthcare workers who are off sick, you're not necessarily, I guess, staffing those surge beds until the need is there. But how quickly can you get those staffed up, and how quickly can you get, whether it's, at Children's Hospital, because I know that's a huge concern right now, or other hospitals, like how quickly can that happen? Can people be confident that that happens within hours, a day, a week? I'm not sure how long it takes.
Well, I'll talk to it a little bit and then I'll turn it over to you. But one of the reasons we've set up the EOCs, the Emergency Operations Centers, like at Children's Hospital and the provincial one that we have, is to be able to do that on a day-to-day basis. So Children's Hospital, they look at all of the pediatric beds around the province and look at how they can staff up in the areas where they're needed. And it varies very rapidly. So sometimes it's a day-by-day thing, and it is dependent very much on healthcare workers. And so there is systems and processes that we have put in place and these emergency operations centers to be able to do that on a day-to-day basis. So it is rapid. The equipment, the pieces are there, so it is finding the healthcare workers to transition into the places where they're needed most. And that's the day-to-day work that people are doing across the province right now as we're heading into more and more respiratory illness.
I mean, I think you're absolutely right to the extent that the higher the population in the hospital, the more pressure there is in the system, and it's unequally felt. One of the places where I think our healthcare workers and nurses have done exceptional work is Royal Inland Hospital, which has a base bed capacity of 258, and it hasn't been at 258 in many, many weeks. And when I say many, many weeks, I say more than 52. Right. So they adjust with surge bed capacity all the time, as do all hospitals. But you want to relieve to the maximum extent possible. And there, we opened long-term care beds at Ponderosa during the pandemic to create capacity. And if necessary, and this is not necessary yet, and we are doing record numbers of surgeries in our healthcare system every month, which is, I think, an extraordinary achievement of the surgical renewal commitment that we put in place. But if necessary, those steps are available as well. You'll recall a year ago, and that was the Delta variant of concern, that we had to transport people from ICUs in the Northern Health Authority in particular, in the hundreds, down to the Southern Health Authority. So we have levels of action that we take in our emergency responses. We're not there, and we don't want to be there. And part of the reason that we prepared every year for what would come in respiratory illness season is to prepare for exactly those scenarios. But it is not easy. I mean, it's just not easy. And if you have some people who are off sick, especially in a smaller hospital, it can profoundly affect your ability to deliver service, which is sometimes why we have diversions, right? Because they're simply, people are off sick and you simply can't replace them in a small period of time safely. So you go on diversion, which is very disconcerting for people, and we know that, and you've been reporting on that. So those are some of the challenges facing the system. So we are able to, but there are limits. And once those numbers go up and up and up and up, then you have to take other actions. The reason we deferred surgeries at different times in the pandemic, in March of 2020, because we weren't sure what was going to happen, and then during the Omicron variant of concern, was to reduce hospital capacity so we could care for more patients. We don't want to do that. It takes enormous effort to make up that ground, and we've been doing it. But there's lots of options available to us. But obviously, some of those options all have other consequences that we don't want to see happen, and that's why we're taking these preventative steps.
Next question, Vaughn Palmer, Vancouver Sun.
Is there any hesitation over bringing back a mask mandate because of the view that the public has moved on and it would be hard to enforce a mask mandate even if you brought one in?
I think I tried to explain that mask mandates were in the context of where we needed them to be worn by everybody over broad areas, over broad settings, in the context that we were in at the time. So I don't see a mandate as being required by itself right now in the situation that we're in. We all need to learn about that tool and where it is best used, and we're trying to provide some guidance on that. And that's what we all need to focus on, because this is going to happen every year. We're going to have respiratory season next year. And masks are one of the tools that are important, that work, that help in the situations where we use them most. So if we're not feeling well, if we're going into a crowded situation with poor ventilation, where people we don't know, those are when we need to wear masks. And that will continue. So right now, I don't see the need for a mask mandate by itself, because we have many other tools and we have a high level of protection from a variety of these respiratory illnesses that are circulating right now.
Thanks. Is there any particular, of all the metrics you monitor, is there any in particular that would contribute to you changing your mind on this?
Yeah, we've talked about that a lot. When it wouldn't be a mask mandate in isolation, it would be what are the measures we need to take to prevent people from getting sick and overwhelming our healthcare system, prevent morbidity and mortality, sickness and death. And so the situations that I can see would be an entirely new virus for which we don't have immunity anymore, where every single one of those tools needs to be in place in a broad way across the population. So it would be in the context of other things that need to be in place too, like capacity limits and restrictions in certain activities and all of those other things that we needed to do when we didn't have protection against something that was causing very severe illness in large numbers of people.
Next question comes from Richard Zussman, Global News.
You describe a scenario there where you wear your mask, close proximity to others, you don't know, poor ventilation. Many people would describe that as a school situation. I know you mentioned that ventilation has been worked on in schools, but there are still a lot of unknowns in that situation. So why is there such a reluctance, considering that kids have largely been able to train themselves to wear masks properly, to put masks in that situation when we've even seen some studies out of the US that community spread has gone down in areas where there's been masking in schools?
So just to address those studies, because these are things that we also have been looking at. And it's not that community spread has gone down. Those are observational studies. And it's hard to know which came first. So community rates went down. Masking was part when the community rates were high, community rates come down. So it's very challenging. They're not cause and effect in those studies. So I suggest that we have a lot of data that shows us that schools are not uncontrolled environments. There are lots of things that children do in schools, and it's really important to normalize that. We've put a lot of pressure on young kids. They've suffered through this pandemic in many, many ways. So it is important for us to make it a very inclusive environment where masks are there, where they're available, where kids can wear them, where they are trained to wear them, where it's normalized when they need to wear them. We're not in a situation right now where I think every single child and adult in a school setting has to wear a mask all the time. That's what a mask mandate is. We're not in that situation. Where we need to pay attention to are all the pieces that go together to make it a safe environment and to give children what they need in a school environment, which is activities and being in person all the time, the social connections, all of the learning that they do in the school community and school environment. And so that's what we're focusing on, making sure that the ventilation is paid attention to, making sure we have the cleaning, making sure kids are taught how to clean their hands and cover their mouth appropriately, and when to wear masks, and to stay home, and to make it easy for children to be able to stay away if they're getting sick.
Follow up, Richard?
On the wait time issue,
You know, it's really important to get vaccinated for children. That's one of the best ways we protect them, even if they're not going to get that sick themselves. It's really important.
on the wait time issue at BC Children's, I know that Minister Dix went over some measures that could work to help address it. People are still facing double-digit hour waits. What should parents do with children looking at that situation, considering in some cases they are having a hard time accessing family help?
That, of course, Provincial Health Officer Bonnie Henry and previously Health Minister Adrian Dix answering questions from reporters. They've been discussing flu season and respiratory illness while reminding the public to get COVID and flu shots, as well as to wash your hands and stay home if you're sick. They say they've seen a large number of kids coming to hospital due to influenza. And when it comes to masks, there's no mandate, but they do recommend using one, especially in areas that might be crowded if you feel like you might be able to catch something. We'll have more on this coming up throughout the day and next on Global BC at noon.
Not to delay going to the emergency department. Call 811, get some advice, but if you need to go, the emergency department will be there for you, and we are working behind the scenes to make sure that we maximize that as much as possible.
And I think I detailed some of the measures we're taking specifically with respect to emergency rooms to assist people who are visiting, who are coming to emergency rooms, especially with children on a given day, including increasing support for patient care coordinators, the work that we're doing in most hospitals, which is really important. BC Children's is a little bit specific, because obviously we don't have ALC beds in BC Children's Hospital, so it's a specific circumstance. But all of the things we've put in place, including the expanded capacity at 811, including we've added a couple in the last few weeks, urgent and primary care centers, which have taken 1.5 million visits and take thousands of visits across the province every day, and coordinating those more closely with emergency rooms. And the work we're doing to both get people supports at home so that they can leave hospitals sooner. One of the challenges in the emergency room in general, and if you're a child outside of the Metro Vancouver, you see that one of the challenges in the emergency room is ensuring that there's access on wards so that people can be transferred to the wards, and it takes off the overall pressure on the emergency room, because that can be problematic for the delivery of care, and obviously problematic for everyone around the care. Makes it feel more crowded than you want it to be in those circumstances. So all of those steps that we're taking are important. And obviously on the primary care question, we've recently working with the province's doctors and all the work we're doing with other groups, including and especially nurses and health sciences professionals and healthcare workers, to increase the attachment to a family doctor. And I think that's work that we did together. We've signed a historic agreement. It's waiting to be ratified, and we've put interim measures in place both to facilitate new to practice doctors to provide care in the community. We're taking steps on internationally educated doctors, and of course the transitional funding which is in place through to January 31st to support doctors in the communities. But look, it's a difficult time. We have seen and we are seeing some significant increased demands, and we respond to those demands. There have been an increase, for example, in Vancouver Coastal Health in gynecological referrals. So our team of surgeons met last week, and we will be increasing that capacity in the coming few weeks. So we respond systematically, and that's why the organization that's been in place in BC's healthcare system since January 2020, which has really been an emergency organization of the system, continues to be needed and required, especially this fall and winter.
Moving to the phones now, our first question comes from Andrea Wu, Globe and Mail.
Hi there. There is recent research showing that even among those who have been immunized, each subsequent COVID infection raises a person's risk of serious complications, including hospitalization, death, or development of disorders affecting the lungs, brain, and heart, and the body's blood, musculoskeletal, and gastrointestinal systems. Does that not warrant a stronger public health response beyond widespread vaccination, especially given that we know that immunity does wane after a few months?
Yeah, I guess, we have to put it in context, and I'm aware of that study. And there's many of those studies that have varying results about impact, and some of it short-term, some of it potentially longer-term. But what we are also seeing on the ground is that we're not seeing as many people develop long COVID symptoms, particularly after vaccination. And we know that vaccination reduces that risk by at least half, maybe more. Since Omicron, we are also not seeing as many people with infections who are developing longer-term symptoms. So I think we have to put that in the context of, we know that those broad measures that we took to prevent transmission had downside impacts on people's health as well. So if we look at the things that you could do, so more public health measures, it would be stopping sick people from being around well people. And that's hard to do. It's hard to know when somebody can transmit potentially asymptomatically. We know that happens with influenza. So we only need to look at places like China, for example, where they are continuing to try and do that, to recognize that there are very severe downside impacts on communities, on families, and on individuals. So I think what we need to do is recognize that the best protection we have is vaccination, and put in place all of the other things that we do individually and collectively to try and get us through this. This virus is going to be with us, so we have to find that balance of not causing more harm from the measures that we put in place and doing our best to protect people. And we've seen, I mean, our evidence is clear that if you're vaccinated and with a level of hybrid immunity that we have right now, most people are not going to get severe illness with COVID. So we have to put in place things that are commensurate with the risk that we're seeing right now.
Follow up, Andrea?
Yes, please. How many pediatric elective surgeries have been canceled or postponed in response to the increase in respiratory infections to date?
I'm not aware of any of them in this province.
I mean, there are on a daily basis occasionally surgeries that are canceled, but essentially across the system. We've been doing record numbers of surgeries. I'm happy, and ordinarily in these reports, when they occur on Thursday, and we'll have the numbers coming in on Thursday, we'll let you know how many surgeries have been performed in BC. But prior to the pandemic, we really never hit 7,000 surgeries. We've hit that mark consistently, and that obviously includes pediatric surgeries. At a particular site, there may be issues on a particular circumstance. For example, a surgeon falls ill or a surgical nurse falls ill, it affects the delivery of the surgery in that case. But in general, we're delivering surgeries at a very high level and at historically high levels right now across the province. That is one place, should the situation become more challenging, where you can adjust to allow for more capacity in the system, but it's obviously not desirable to delay surgeries that people need, since all the surgeries we deliver in the public healthcare system are medically necessary.
We have time for another question from the phones before we come back to the room. Next, we hear from Wildenette Paul, Radio-Canada.
Merci beaucoup. Bonjour, Adrienne Dix, ici Wildenette de Radio-Canada. Ma question, c'est sur le port du masque. Vous l'avez mentionné aujourd'hui, le masque n'est pas obligatoire. Le Québec recommande le port du masque dans certains lieux publics achalandés. J'aimerais savoir qu'en est-il pour la Colombie-Britannique. Est-ce qu'on le recommande? Est-ce qu'on laisse le choix au public? Alors, sur le masque, qu'est-ce qu'on recommande ici dans la province?
C'est ça. Je pense que les conseils de notre système de santé sont de même d'autres provinces, à une exception importante. Nous avons des mesures en place dans le système de santé qu'on n'a pas en Ontario ni au Québec, n'est-ce pas, qui maintiennent qu'il faut avoir un masque dans des hôpitaux, etc., mais aussi dans des centres de soins à long terme. Donc ça, c'est important et essentiel. C'est aussi important de noter dans notre système de santé publique, c'était obligatoire pour les employés d'être vaccinés, ce qui n'est pas en place dans d'autres provinces du Canada. Je ne fais pas du tout de commentaires sur ce qu'ils font. Je pense que les efforts un peu partout au Canada sont exceptionnels et j'ai eu l'occasion d'en parler avec le ministre Dubé la semaine dernière. Je pense que l'effort au Québec est extraordinaire, mais je pense qu'il y a des particularités. Et sur la question des masques, la particularité de la Colombie-Britannique, c'est qu'on a un mandat dans notre système de santé.
Follow-up, Wildenette?
Oui, j'aimerais revenir sur la question, encore une fois, M. Dix, pour le masque. Qu'est-ce qu'on dit aux Britanno-Colombiens? Est-ce qu'on le recommande? Est-ce qu'on le conseille? Est-ce qu'on dit portez-le dans les lieux publics? Alors, quelle est la position de la Colombie-Britannique en ce moment sur le port du masque?
Simple. Je pense que nous prenons des mesures alors que ces mesures sont nécessaires. Nous suivons les conseils de Dr. Henry et son équipe sur ces questions. C'est important de reconnaître que souvent il y a des circonstances où il est important de porter un masque pour votre propre protection et la protection souvent des gens qu'on aime dans notre propre famille. C'est important. Donc, souvent, quand je vais, par exemple, à Sévenfou, je porte un masque. C'est normal. Mais l'autre, et nous avons un système de mandat dans notre système de santé. Ailleurs, nous avons des recommandations de la santé publique et nous allons continuer à les suivre. Je pense que c'est important ici de comprendre que c'est une façon de se protéger contre le COVID-19 et d'autres maladies respiratoires. Mais il y a une combinaison, et la plus importante de toutes ces mesures, c'est la vaccination. La vaccination, et j'encourage tout le monde d'être vacciné cette semaine. Il y a des rendez-vous ouverts aujourd'hui, et c'est que ce soit contre le COVID-19 ou autre chose, je pense que c'est essentiel que les gens prennent cette mesure fondamentale pour se protéger contre le COVID-19 en particulier, mais d'autres maladies respiratoires.
Final question from the phones before we finish here in the room. Lisa Eustace, City News 1130.
Hi there, Minister. Sorry, I'm just going to take it up here. And I don't know if I missed this before, but I wonder if you could address specifically the wait times at ERs for children and for adults. What is being done to address that? And I know you talked about it a bit earlier, and I'm sorry if I missed the entire answer.
So what we're seeing across the province is a relative increase, right? We used to use this number of about 6,500, which is average in front before COVID-19. I was going to say COVID-19, COVID-19 in BC. In November so far, our average is 6,765. That's differently felt at different hospitals and in different communities. So we put in place, as we do in periods of high volume, which are, by the way, every year during respiratory illness season, but it's more important this year because of COVID-19 in addition to influenza. So we put in place a number of measures, and we're continuing to put in place measures to ensure that those who can be in long-term care and are slated to be in long-term care, that some of those people are able to move to long-term care to create more space in the hospital. This allows us to improve flow from emergency room, and that's really important for everybody who works there and everyone who gets care. We're putting in place more patient care coordinators. We have resources, for example, at 811 available to people to get advice on the phone, and people are using those resources. We've seen a very significant increase in utilization during COVID-19, but we've maintained the resources, for example, yesterday, to answer the 1,800 calls that we received through the 811 line. And we're increasing the collaboration between urgent and primary care centers and ERs across the province. There are now more than 30 urgent and primary care centers, and they've seen more than 1.5 million patients now up to date, which is a pretty significant contribution as well. So all of these steps are being taken. They're important steps, but we have to know, and we have to know in this period of respiratory illness that there is going to be, and is, more pressure on emergency rooms. You see it in the numbers, but you see it in the reality of those emergency rooms. And it can be in different emergency rooms, different on different days. And that means that, that if you need to go to an emergency room, go. You will be triaged, and it may take some time because we triage cases. So if your child or your case or an adult's case is less serious than other cases, they are going to be seen first. That is the way we operate emergency rooms here and everywhere else for good reason. But that's the effort that's being made. Specific actions to support emergency rooms now. All the steps that we're taking to reinforce primary care, and specific actions to improve patient flow in our hospitals, which is important for patients. It sounds a technical term, important for patients, because it means that we don't have people stuck in emergency rooms longer than they need to be stuck.
Follow up, Lisa?
Just so the bottom line is that with the pressures that are coming with this respiratory season, things are not going to get a lot better for hospitals. You know, I know in Metro Vancouver people wait a long time, but what is being done, what can be done is being done, but ultimately people are still going to have to wait.
You know, and it's going to change on a day-by-day basis. You know, the things that we do as a community to try and prevent ourselves from getting sick makes a big difference. And those are things that we can focus on, that we can do. Getting vaccinated, taking those measures, staying away from others so we're not spreading it if we're sick ourselves. And using the other tools in our community like 811 to get advice about things. But you're right, we have committees, the emergency operations centers, who are trying to manage flow as best we can so that we can make it as efficient as possible. But these are challenging times, and it's challenging times for healthcare workers who are doing their best to try and see people as quickly as possible across the province.
Our last question today comes from Rob Buff from CTV Vancouver Island.
Thanks for taking my question. We are about a month away from the heart of the holiday season. People are going to be traveling around. They're going to be going to parties, hosting parties. We're also going to be a month deeper into this virus season. How confident are you that we are not going to see any form of restrictions, whether it's masks or otherwise, implemented then? And what kind of metrics would you need to see to do that?
We are heading into holiday season. It varies year by year when we see peaks and how steep those peaks are. So we're seeing influenza rapidly increase. We've seen COVID kind of level off and go down. It's hard to know what's going to happen, and we need to be prepared for it lasting several weeks. Normally what we see is that the holiday season is an amplifier for influenza. We're seeing it start early now. So really we have the warning now that we can do things that will make a difference over the next few weeks. And then we all need to think about what we're going to do over the holiday season to make sure that we're not putting people who are more at risk. So if being able to cancel some of those events, if we're sick or somebody's in the family sick, moving it to a safer venue outdoors or where there's more space. So those are things that we all need to think about. I don't see us needing to put in place additional restrictions, but we're going to watch this, of course. And it depends a lot about the impact on our healthcare system, how we're managing that, and we'll be watching that very carefully. We'll be looking at how much it goes up, who's getting sick. So those are all the things that we'll be reporting. The respiratory dashboard, as I mentioned, is updated every Thursday so people can look themselves. But traditionally what we have seen is that comes through in waves. I shouldn't use the term waves. It comes through in surges, in different age groups, different viruses, and we've seen that. We've seen enterovirus, and now we're seeing influenza come up. So we'll be tracking it really carefully to see what happens over the next few weeks. But I don't foresee we'll have to do broad community-based measures in the way that we needed to do last year, given the impact that we saw last year.
Follow up, Rob?
I do, and it's for a colleague who's doing a story based out of Nanaimo, where there's a woman who was diagnosed with colon cancer. She can't get insurance without a doctor's note, and doesn't have access to a doctor. I guess it relates to primary care again. I know the province has brought in this new model for funding GPs, but before we reap the benefits of that, what do you say to families like this one in Nanaimo who are struggling that they can't get a doctor? Is there anything that you're able to do and will do before we see the benefits of this new model to attract or retain doctors?
What I'd suggest, Rob, is if you can communicate the details to my office, because I understand some of the details of what the difficulty might be in terms of getting a doctor's note, but I'd be interested getting all the details and seeing what we can do to help this person in those circumstances. In a general sense, what we have to continue to do is, and Nanaimo has one of our most successful, for example, urgent and primary care centers, which has had a lot of positive impact there. It's very much integrated into the primary care system, and in fact operates out of the medical arts building, and is an expansion of the medical arts center and is an expansion of the services they provide. We're building out primary care networks, more than 1,200 new people to provide team-based care across communities. And so we're providing a lot of those services and taking a lot of action in primary care, the change and the addition, doubling the number of nurse practitioners, and obviously the work we're doing with doctors. But it's difficult to talk about a specific case without knowing the details of that case. But if you provide them, I'd be happy to look into it personally and see what can be done. Okay, thank you everybody. Merci beaucoup.